Hello, dear colleagues and friends from Russia. My name is Gustavo Mantovani from São Paulo, Brazil. I would like to thank the organizing committee for inviting me for this lecture, and personally, my friends Dr. Igor Golubev and Dr. Nikolai Karpinski from the IWAS group. I must state that this is not supposed to be a conventional lecture, since I will present a very personal impression regarding some of the controversies around wrist anatomy, based on 15 years of arthroscopic surgery observation. The main goal of this lecture is to be provocative and to raise on many of you the questioning of some anatomical principles and maybe to promote further investigation to prove or to refuse these hypotheses. I have no disclosures for this lecture. As a brief introduction, all the scientific knowledge come from a constant evolution, one step after other, and sometimes one step backwards or moving in other directions. The important is to keep the questioning and the curiosity, even over the most well established truths, and this is also valid to the anatomy. All the knowledge we have upon anatomy come basically from nature observation. The science first step is the observation and the formulation of the concepts and ideas. The great masters and geniuses of antiquity are example, and they founded the basis of the modern human knowledge. In the human anatomy, most of our knowledge came from the cadaver dissections. The study of the dead bodies, healthy or ill, provided almost all the anatomic knowledge we currently possess. The understanding of the joint biomechanics and correlated to the anatomy is one of our great challenges in the orthopedic research, and for us hand surgeons, the full understanding of the wrist function is the ultimate quest. The advances in technology provided us better tools to investigate and to understand the human body. And concerning the joints, the arthroscope was an important instrument. Since the creation and the use of this optical tool, the surgeons could have a new perspective of the joint's anatomy, new and better vision from inside. At the beginning, the arthroscopy was blamed by the traditional surgeons. Why look through a keyhole if I can open the door? That was the question made by important surgeons. But we know very well, most of times we do not respect the door, and maybe there was important things on the back side of this door. Or the door itself is very important and should be preserved. So let us leave this door and keyhole metaphor behind, because for me, the arthroscopy is much more related to improving the vision than restricting the vision. For me, the arthroscope is much more like a telescope. The telescope makes us see further, distant, beyond our natural view. And the kind of telescope, the type of the equipment makes a lot of difference. Concerning the arthroscopy, we can say we are far away from the first arthroscopic image of the 1950s. This is the Cassiopeia constellation on a regular telescope. Now let's move for a more potent equipment. The richness of image and the new stars and new elements are notable. Let's move forward in technology for the actual space orbital telescopes. The image is even richer and more detailed. And now we have this Hubble telescope in space, removing all the atmospheric effects and providing many technological tools and sensors. And let us check the exact same spot on the space, the Cassiopeia constellation. The quality of the image and new details are very impressive, almost completely different of the best Earth-based telescopes. And this moves on. See how the Hubble telescope can be surpassed by the James Webb telescope. New types of sensors, new lens, better computing. The point is, the information provided to a scientist to analyze and to formulate the concepts, ideas, hypotheses, and the tools to comprove it are totally different. And this may lead to a complete different result. Finally, how can we expect same results in such different conditions, such different source of information? The same happens when we compare the information just from a cadaver dissection and the information from an arthroscopic in vivo evaluation. The last decades, we could see injuries, pathologies, instabilities of the wrist from a new angle, closer, wider, from inside, without disrupting important structures. We found injuries like this one on the right from the ulnar side of the wrist that we never detected before, or like the left, we understand different patterns and combinations of injuries on a scapholonated dissociation. Finally, after this introduction, I want to share with you what had changed in my personal practice on the last 15 years using the arthroscope. I focused to this lecture on these two major sites where I noticed the most significant and potential shift of concepts, the trapeziometacarpal and scapholonate joint. Let's start with the trapeziometacarpal joint. This joint is so relevant for the capital function of the thumb and being this joint so commonly affected by overload and arthritis. The major relevance of the topic is the prevalence and importance of the wrist arthrosis, and wrist arthrosis is equal to instability. Thus, the academic research reflected on literature shows a constant search for the understanding of trapeziometacarpal joint biomechanics and stability. This is a good example of the high-quality research paper. It comes from the most known scientists on the field in the most rich and well-funded institutions in US. You may see there is no limitations for the technological tools to understand how the diverse ligaments of this joint works. This is a good example of how technology provides the tools to move further in the scientific knowledge. But there is a problem. You will just find something that you are looking for, no matter how brilliant you are and how powerful are your tools. And to know what are you studying, what are you looking for, you must start from the basis, from the anatomy, the simple forms of observation and descriptions, and of course, we always use the best studies done before us. So this is one of the most classical papers regarding trapeziometacarpal joint anatomy from the Mayo Clinic in the United States. This paper is so well done and complete that serves as basis and reference from many and most of the further biomechanical studies after it. But what happens if some important information is missing here, or if is misunderstood? From all the ligaments involved in trapeziometacarpal instability, there is a small paragraph mentioning one of them, the intermetacarpal ligament, or first intermetacarpal ligament. The major importance were given to the volar oblique and the dorsal oblique ligaments, and even to the capsule, but nothing for the intermetacarpal ligament. And all we hear about the intermetacarpal ligament description in this important paper is that this is somehow or somewhat confusing and variable. If I am a researcher after this paper, I would not give any importance for this tiny little ligament after reading this. Besides, it is between the intermetacarpal bones, is not even connecting the two major bones of this joint. So how it could be eventually important? So I tried to understand why the authors reach this statement, and I checked the three references on this paragraph. The first reference of this paragraph comes from the Mayo Clinic, another Mayo Clinic work concerning the biomechanical relevance of each ligament. They conducted a cadaver simulation of the loads on the trapeziometacarpal joint and made sequential sectioning of the different ligaments. It was a very well done study, but of course, simulating in vivo condition is never perfect. Besides, there is a lot of influence on the sequence of the sections, and the load was simulating a physiological and specific condition. In this paper conditions, they did not found any relevance of the intermetacarpal ligament. So for this paper, it seems to not be so important. Let's move to the second reference. It is a paper from Edinburgh in the 80s. It was an anatomic study from the trapeziometacarpal joint ligaments made on 17 cadaver specimens dissected for this study. In the summary, you can see clearly the statement that the intermetacarpal ligament sectioning by its own is enough to provide dorsal radial dislocation present on the arthritis. And the paper also found a direct correlation between arthritic joint specimens with the attenuation of the intermetacarpal ligament. This paper also reinforced the relevance of the intermetacarpal ligament and this association between wrist arthrosis with the damage of this ligament. The only doubt that remains on this paper is the cause-effect concept. or to prove the cause effect. What comes first, the intermetacarpal ligament injury or the wrist arthrosis? It was not able to prove. But there was no confusing words on this paper about the evidence of the importance of the intermetacarpal ligament. For these authors, this ligament is a key piece in the biomechanics and the wrist arthrosis evolution. It's very clear. So let's move to the third reference from 1976. It's another strong anatomical study with a very detailed dissection of the intermetacarpal ligament and showing how complex is its structure, what suggests there is a mechanical importance and some isometric pivotal location of this ligament. And also, the authors conclude this ligament is very important and should be a key for a better understanding of the movements of this joint. So at the end, from the three references, two are very assertive, saying that the ligament, the intermetacarpal ligament, may be the most important ligament for the trapeziometacarpal joint instability. And only one paper from the colleagues of the same institution found a different result. And then the statement, somehow confusing and variable, maybe was made to not contradict these colleagues. Finally, what the nature observation tells us. Using the arthroscopy for treating the wrist arthrosis on the last 10 years, I had opportunity to study the pathological anatomy of this joint from inside, since the first step of arthroscopy is a joint inspection and diagnostic. So what did we find? I show you here in this video a summary of our experience during this decade treating the wrist arthrosis. I selected 4 different stages, and you can see and demonstrate very precisely the different stages correlate with different attenuation and injury phases of the intermetacarpal ligament. So we can see in the first stage the ligament can be attenuated, can be shown inflammatory aspect, and can be initially ruptured. In the last stage, we can find the ligament in a more advanced phases of destruction. So this is, you can see in the video, the first stages. We collected some samples also for histological examination, but it's not done yet. And in the second stage, you can see there the stumps of the ligament with a fibrous aspect. It means in a evolution of rupture compared to the previous one, the most advanced one, and you have a more advanced stage of arthritis. In the third stage, we can see the same aspect, but now with some calcified aspect. We can see the calcified, and eventually those calcified stumps can be released as free bodies. In the last stage, what we found in the area of the intermetacarpal ligament is the medial osteophyte. So probably there is a correlation of the last stage of ligament calcification and the formation of the medial osteophyte. But the important thing is, in every single case, in the different stages of evolution of the disease, the volar and the oblique dorsal ligaments, the dorsal oblique and the volar oblique ligaments are always normal. So, based on our arthroscopic experience and based on this review of the literature, for me, there is no doubt about the relevance of the first intermetacarpal ligament on the etiology of the wrist arthrosis. It is clear for me that the disease starts with an injury of this ligament, because we correlated the injury of the ligament with the different stages of the disease, and we found the other ligaments completely normal. This is very important because for the first time, we can have confidence to propose new surgical protocols for treating the early stages of this disease and avoid the evolution of the wrist arthrosis. These new protocols should aim for the first intermetacarpal ligament anatomical reconstruction. There is already some techniques published in literature that could be used for this early stage when the instability and the injury of this ligament is confirmed arthroscopically. These new protocols should aim for the anatomical reconstruction, and this is how a summary of our proposed technique, which we are using actually for treating the most early stage of wrist arthrosis when we found the instability, using a strip of the extensor carpi radialis longus. So we used this strip and we made a stabilization in the anatomical point of the intermetacarpal ligament using a bone tunnel and different methods of fixation. You can see how it looks like, and the fixation method can be variable in different ways. So let's move for the next topic, where arthroscopy changed completely my understanding of anatomy and mechanics, the scapholonate joint. First of all, we must say that we understand now the scapholonate joint as a scapholonate complex. It means it's a joint stabilized by a variable number of structures. The use of the arthroscopy provided us the knowledge of those structures, the capsule structures, some structures that was previously damaged during the common open approach. And the DCSS, the dorsal capsule scaphoid septum, is a perfect example of that. The group of Iowas described the DCSS and proved its biomechanical relevance, acting as a connector of the different important extrinsic stabilizers of the scapholonate joint. In the same way, the knowledge obtained using the arthroscopic approach in different arthroscopic techniques shown us the secondary stabilizers were in fact the major stabilizers, since we start to find several different presentations of these injuries. The DCSS appears as a real connector of those extrinsic ligaments, and its injuries increase scapholonate instability. There was more anatomical studies made around the DCSS showing more details about this structure. And using the arthroscopy, we notice that many cases of scapholonate instability with a total disrupture of the intrinsic scapholonate ligament doesn't have a so bad instability because the extrinsic ligaments were intact. In the other hand, normal scapholonate intrinsic ligament can have severe instabilities like stage 3 of Geisler instabilities because they have a disrupture of the attachments of the extrinsic ligaments. So the dorsal and volar insertion of the extrinsic ligaments plays a more important role to this joint, and the DIC probably is the most important of all of those. And again, what we learned from over a decade of arthroscopy treating scapholonate injuries. We learned that there is not a simple case, but a constellation of different patterns of injuries. We know that the scapholonate intrinsic ligament is the less relevant, but the capsular extrinsic ligaments are more important. And that explains why there is no universal recipe to treat all the scapholonate dissociations. So it's a constellation of different injuries with many different patterns depending of each one of the components of the scapholonate complex are included. So what is important in this condition is a tailor-made decision. We must adapt our different treatments or different techniques for the specific condition we found in the arthroscopy. And how do we manage this? We move from the more simple procedures to the most complex according the findings we have in the arthroscopy. So from the simple capsulodesis techniques until the more complex reconstructions and tenoplasties. A good example for the most simple situations and techniques is the capsulodesis proposed by Matula. And this capsulodesis is interesting because it works exactly like a suture or a repair of the DCSS. So it's a perfect indication in cases like that for the symptomatic dorsal ganglions where you find in the arthroscopic inspection instability of the scapholonate. It means a pre-dynamic instability. You can see in this example, we perform a synovectomy, and then when we check the mid-carpal joint right now, we can see a stage 3 instability, even if in the situation that the scapholonate ligament is completely normal. So now we perform the conventional resection of the cyst, but we will not do only the resection because we have known instability. So we're going to perform a reinforcement of the DCSS using the Matulin technique. And now you can see the step-by-step of the Matulin technique with the suture of the capsule or the dorsal aspect of the capsule in the intact scapholunate ligament. And this can reinforce the stability, and this will treat the cause of the pain, not only resecting the cyst that is in fact a sign of the problem or an effect of the problem. You can see in this image how the knot stay in the mid-carpal aspect of the scapholunate joint, and tensioning this, you see the stability is achieved in the moment. So it's a more rational way to treat those cases. And what can we do in the more severe instability, in the static cases? Can we jump direct to the more complex tenoplasty, bone tunnels reconstructions? No, we can perform what we call the supermatula or a supercapsuloplasty. It's a technique that can provide a stronger stabilization based on application of the dorsal capsule, and the DIC very strong and very reliable on the first row, in the bones of the first row. And this animation shows the example of how the techniques works. So for the chronic cases, it's important to make a debridement in order to promote a good scar and a good footprint for the healing. And then we're gonna make a double suture, one suture in the radial aspect on the insertions on the scaphoid, the insertions of the DIC in the scaphoid, in this way shown in the animation. And the second suture is made in the medial insertions of the DIC. After that, we pass to the radiocarpal joint and we retrieve these two double sutures through the radiocarpal joint in the middle of the scapholunate, and we promote the inclusion of the DRC on this plication. So it has a very strong mechanical effect. We can see here how it works in a clinical case. So we see our proof of concept in the cadaver specimen. You see there we made an injury of the scapholunate, and then we see how strong is the effect of the tensioning of our suture. We move from a stage 4 to a stage 1, and then we can see how it looks like in a clinical case. We see the exploration of the joint at the beginning. In this case, we have a complete unstable stage 4 with a full avulsion of the dorsal aspect of the scapholunate and DIC from the proximal part of the scaphoid. We must check the distal insertion of the DIC if it's okay. Then we promote the scar, the footprint for the scar, as I mentioned before. We can see in this case floating lunate situation because there is also instability of the lunotriquetral joint. This is probably because of attenuation of the DIC. And here you see the pass-through sign where the optics is completely passing in between the scapholunate joint. Now you see the steps of the suture as I shown in the animation. First in the radial side, and then in the medial side of the DIC. You can see that the needle can go directly through the skin because the suture will stay only in the capsular level, so there is no risk for entrapment of the tendons or other structures. You make this in-out movement and the thread will stay only in the capsule. So after retrieving these two lassos, these two sutures, we're gonna pass these sutures to the radiocarpal joint. And this passing is very similar of the steps of the Matulin technique. So we pass the two needles with a kind of lasso in the tip, and then we can retreat these sutures for the radiocarpal joint by the 3-4 portal. So it's a very reproducible and simple technique, minimally aggressive one with no risks of making the bone tunnels or using complicated and complex implants. And then you see the effect, a very strong stabilization effect after tensioning the suture. And the final knot is made out of traction. So it's a way to make a more simple and reproducible and less aggressive treatment, even in a more complex instabilities of the joint, of the scapholunate joint. The interesting thing is that you not jump and not burn any bridge. So this is how radiological aspect at the long term for this patient on the video. This is the clinical result for this patient of the video. Of course, there is a little limitation in flexion because of the scar. And this is a last example in a high performance athlete where we use anchors to reattach the DIC on the distal part of the scaphoid. And you check how strong is the scar tissue formed in the dorsal aspect of the scapholunate. And this is a very high demand patient. So in conclusion, for the second trend, the second conclusion around the scapholunate complex, scapholunate instability or dissociation is much more than a simple scapholunate ligament injury. There is a ligament complex involved and many different patterns and presentations can be found. Remember the DIC as the major stabilizer of the SL joint, and it can be used in capsular techniques for more simple surgeries and less aggressive surgeries. So also remember about the more simple instabilities and scapholunate pre-dynamic instabilities associated to symptomatic dorsal ganglions. Thank you very much for the invitation again and for the opportunity.